Before 1986, patient dumping was common. Private hospitals would screen patients in the ER. If they didn't have insurance, the hospital would put them in an ambulance and dump them at the county hospital, even if they were unstable. They performed wallet biopsies before medical biopsies. There were horror stories of women in active labor being turned away from ER doors because they couldn't pay. Congress decided this was morally repugnant. They passed EMTALA to stop it. EMTALA imposed 3 duties on any hospital that accepts Medicare, which is basically all of them. First, you must provide a medical screening exam, MSE, to anyone who shows up, regardless of ability to pay. Second, if they have an emergency medical condition, you must stabilize them. Third, you can only transfer them if they are stable, or if the medical benefits of transfer outweigh the risks. You cannot transfer for economic reasons. It created a legal right to emergency care. The catch? Congress didn't pay for it. It is an unfunded mandate. The government said, you must treat them, but didn't provide a budget. Hospitals had to eat the cost of this uncompensated care. To survive, hospitals raised prices on private insurance, cost shifting. But in poor areas where few people had private insurance, hospitals couldn't shift the cost. They just went broke. Ironically, a law designed to help the poor led to the closure of many inner city and rural ERs, reducing access in the very communities it was meant to protect. Over time, the definition of emergency expanded. It came to include psychiatric crises, active labor, and severe pain. Because the ER was the only place required by law to see you, it became the everything room. If you have a toothache and no dentist, you go to the ER. If you need a refill on psych meds, you go to the ER. The ER became the primary care clinic for the poor, which is the most expensive and inefficient way to deliver primary care. We are using a Maserati to deliver a pizza. EMTALA also applies to the specialists on call. If the ER doctor calls the neurosurgeon must come in, even if the patient can't pay. Specialists rebelled. They started refusing to take ER call. They said, why should I wake up at 2 a.m. to do a free surgery and risk a malpractice suit? Hospitals had to start paying massive stipends to get specialists to cover the ER. This drove up the cost of healthcare even further. It turned the medical staff against the administration. EMTALA also collided with managed care. Insurance companies want you to get pre-authorization. EMTALA forbids you from delaying the screening exam to ask for insurance information. You cannot ask, how will you pay? Until asterisk after asterisk, you have stabilized the patient. This creates a zone where the hospital is flying blind financially. It protects the patient's dignity, but it wreaks havoc on the hospital's revenue cycle. We saw in Module 4 how EMTALA was used in the baby K case to force the treatment of an anencephalic infant. This shows the unintended consequence of legalism. A law designed to prevent economic discrimination was weaponized to override medical judgment about futility. Because the law says, stabilize the emergency, and respiratory distress is an emergency. The doctor acts as a technician, not a clinician. The law stripped the professional of the power to say, this treatment is inappropriate. Today, the biggest EMTALA crisis is psychiatric boarding. A suicidal patient comes to the ER. EMTALA says you must stabilize them. You can't send them home. Unsafe. But there are no inpatient psych beds, thanks to deinstitutionalization. So the patient sits in the ER hallway for days or weeks. The ER cannot treat them effectively, but cannot release them legally. This boarding clogs the ER, increasing wait times for everyone else. It is a systemic failure concentrating in one room. To conclude, Lesson 2, EMTALA is a moral success. It established that in America, you will not die on the doorstep of a hospital because you are poor, but it is a structural failure. By creating a right to emergency care without a right to primary care, we distorted the entire system. We built a safety net that is incredibly expensive and catches people only after they have fallen off the cliff. In the next lesson, we will look at how we measure success in these programs. We will discuss program evaluation and the Ryan White Care Act. If you want to understand why your local ER has a 6-hour wait time, read up on the history of EMTALA. It explains almost everything about the modern hospital crisis. See you in Lesson 3.